have to tell this group that, whoop, there we go. I don't have to tell this group that the population is aging, and that with the predictions really being that 1 out of every 5 Americans in the next decade is going to be older than 65 years old. What you may not have spent as much time thinking about, however, is how this will impact the emergency department. So 75% of these folks will visit the ED in the last 6 months of their life, and over half of them will be in the ED in the last month of their life. And so what you also may not have spent a ton of time reflecting on is the impact that this has on our practice in the emergency department. And so our practice, our patients have really shifted from the chief complaints of the emergent, traumatic, imminently life-threatening diagnoses that many of us went into this specialty thinking about, instead to the reality of our practice now, which is that we are caring for patients who come to the emergency department for functional loss, for uncontrolled chronic symptoms, and for caregiver fatigue. And so that makes sense, right? That patients are living longer, and so they're living long enough to develop end-stage organ disease, cancer, dementia, and that the ED is really the place where many of them get their care. And so as Tammy Quest, who actually spoke with you all 2 years ago, she's really the sort of leader in emergency medicine palliative care. This is how she puts it, that we are, in the emergency department, the safety net for the acute and chronically seriously ill. And despite that, it's interesting that these patients' principal problems are often readily overlooked in the emergency department. And so here are some quotes from our very own residents who have sort of approached these issues as subacute issues, as social barriers to discharge, or my favorite, which is important for the inpatient team to know about, right? And so, you know, the question is, exactly how big an opportunity is this? And so here it is by the numbers. So we see in emergency departments across the United States, we see 116 million visits every year. And 1.1 million of those come from nursing homes, with an unknown number of those coming from hospice, which I think is a very interesting number that we need to understand more about. 14 million of those patients end up with inpatient admissions. 1.6 of those go to the ICU, and almost 140,000 patients die in the emergency department. So if that's who we are by the numbers, if that's what the landscape looks like, who are we by self-definition in emergency medicine? And I think many of us would say with pride that we are resourceful, that we're a jack of all trades, that we're diagnosticians, we're nimble, and we're problem solvers. And these are all skills that you could think would be very applicable to palliative care and doing this work in the emergency department. However, folks would also acknowledge that we are a little bit frenetic, that we are easily distracted, that we are laser focused on this initial diagnostic evaluation, and often really on that ultimate disposition. That we really value efficiency, and that we work in an environment that is overcrowded, that has a tremendous amount of boarding, and is a medical legal minefield. And so these are really challenges, both in the physical environment and with the providers, to often thinking about doing this work really well. So despite this, we know that there's an opportunity. So as we saw, there's no shortage of patients with life-limiting illness who are coming into our emergency departments towards the end of life. But additionally, there's mounting evidence to suggest that bringing palliative care closer to the emergency department could yield really important patient and system level changes. And so what is that evidence? So studies here have really been looking at linking the timing of palliative care with really important outcomes, the outcomes that you see here on the left. And so again, this isn't sort of the impact of palliative care writ large, that evidence you're very familiar with. You're probably very familiar with this evidence as well. But these are the studies that are really saying what happens when we move palliative care just a few days earlier in a hospital inpatient admission. Or what happens if we really get it out into the community with community-based palliative care programs? What kind of impact does that have on patients who are hospitalized or at home? And so these are the types of outcomes that they've looked at: hospital length of stay, mortality, quality of life, cost. And then interesting, they've looked at these interventions have led to decreased ED visits and ED bounce backs. And one of the challenges here is that they've looked at the ED as an outcome rather than an intervention. And that, I think, is one of the challenges a little bit. And so still the question then remains, what if in patients who arrive in the hospital, we could actually have emergency medicine or have palliative care in the emergency department? And so 2 studies did look at this. So the first one is admittedly imperfect, but large. And so this study compared the trajectory of patients who had palliative care needs identified in the emergency department versus those who had palliative care consults once they hit the floor. And they actually did propensity scores. They calculated propensity scores to try to match these cohorts. And it's a pretty big study. They looked at over 1,400 palliative care consults over a 4-year period. And what they found was that those who had palliative care consults in the emergency department had a significantly shorter, like on the average of 3.5 days shorter length of stay in the hospital, which is pretty significant. The second study that's really looked at this question of the impact of emergency medicine palliative care was a little more rigorous. It was a randomized study, and what they looked at were really the patient population with advanced cancer, and they randomized them to receive a palliative care consultation by palliative care experts in the emergency department, or again, usual care. And what they found, also sort of a positive study, what they found was that the patients who received palliative care consultation in the emergency department had significantly higher self-assessed quality of life scores than those who got it much later in their inpatient stay, which is what they ended up finding out usual care really amounted to, was significantly later engagement of palliative care during that inpatient stay. So decreased length of stay and increased quality of life. So that's really the whole landscape of the literature that has looked at the outcomes or the impact of palliative care in the emergency department, which is pretty remarkable. So that doesn't mean that other things haven't been written, right? So although there's sort of a dearth of literature on the outcomes or the impact, there are lots of other articles in the palliative care sort of emergency medicine space that instead really focus on this sort of abundance of articles that talk about the promise, possible approaches, that think about the content of curriculums. And so there's been a lot of writing around that. And so when we take all of it together, you know, all the writing around the promise and the possibilities and the curriculums with the small, you know, couple of articles that really look at outcomes, and then really the larger body of evidence that looks at the outcomes of community-based palliative care and palliative care earlier in hospitalizations, I think these are the things that we believe we could reasonably expect to see if we were able to systematically provide palliative care to the right group of patients in the emergency department. So things like improved control of symptoms, reduced family anxiety. Several articles looking at earlier engagement of palliative care have looked at things like lower PTSD for families, timely implementation of care plans that are more consistent with patient preferences, community resources. And that's a really interesting one that we're talking a lot about now. We think about our emergency medicine patients who get discharged, right? Those are folks that are not going to get a palliative care consult on hospital day 3 because they won't be here. And so how can we leverage this opportunity, this touch point with them, to connect them with resources that they may need in the community? And then there are lots of these sort of efficiency metrics that have been very promising. So the question is, what do we know about how to actually make this work? And so we know that, well, actually, before we get there, we can just a quick moment on some of the solution sets that are already out there. And so here, when we think about how to actually do this work, the question is how do we identify who these patients are? And so although we haven't looked rigorously in emergency medicine about the outcomes, what we did realize when we started thinking about this work is that we need a way to identify these patients. So we know that every patient that walks through our door does not have unmet palliative care needs, right? And so the question is, how do you figure out who they are? And so that one question probably makes up the bulk of the rigorous emergency medicine palliative care research. And so started off with a lot of work being done in the last decade or so, trying to figure out screening tools that would help us identify who these patients are. Now, the truth about these screening tools is that although they were all developed with very rigorous Delphi methods, they have largely not been adopted. And they haven't been adopted because they've just been a little too cumbersome to apply. So although they felt really good in groups of experts around tables, when brought to the bedside, they really didn't work. And so, these tools, the early tools in this space, the core components of them make so much sense, right? They are the things that we know are important to understand. Have these patients been back and forth to the emergency department several times? Do they have uncontrolled symptoms? Functional decline? Are they getting increasingly complicated? Advanced end-stage disease? And then they bounce into these sort of secondary screens beyond that. But just with the complexity of the tools, they're just not really being used. And so that led us to wondering, could we boil this down into just like one question that we could ask to help us identify who are the patients who could potentially benefit from palliative care in the emergency department? And so we looked at the literature, and we found that the surprise question, what you see here, is the incredible amount of work and research that's gone into thinking about the surprise question in other care settings. And so we started to think that this may have some promise. And so the surprise question, I'm sure everyone in this room is familiar with it, but this idea of, would you be surprised if your patient died in the next 12 months or 6 months? Different studies have used different time thresholds. But just asking that one simple question, and if the answer to that question is no, I wouldn't be surprised, then that in and of itself can be a trigger to suggest that this patient may benefit from palliative care engagement. So we looked at the literature and said, wow, they've looked at this in all these other environments and all these other patient populations. What if we looked at it in the emergency department? And so that's what we did. And we've done this now twice. Initially, we looked at it in just older adults. So in folks, although I sort of cringe when I say what our older adult cutoff was, but we borrowed mainly from the literature with this idea of 65 and older. And then we looked at within the heart failure population specifically. And it was really exciting. In both of them, this question alone showed reasonable promise. So to that end, the question has really become, once you've identified these patients who could potentially benefit from palliative care engagement in the emergency department, then what do you do with them, right? So does the emergency clinician pull up a seat and try on their best hope worry? Do we, call from upstairs and get a full palliative care consult? Is there something in between? Is there a focused assessment? And sort of musings on this have also made up a huge amount of the emergency medicine palliative care literature. Sort of how best do we design this? And frankly, the jury is still out. But really, regardless of the debate about how much primary palliative care is optimal or even realistic in the emergency department, one thing is clear is that this really is an evolution. And that when we think about the relationship between emergency medicine and palliative care, it seems that there is a journey with these different models. And so I think that given how much has been written about this, it makes sense to just take a moment to mention it. And so here, I actually realized that you're reading here from left to right. But this idea that it goes from the traditional consultation model all the way to this ED-focused integration model. And this is really the framework that folks in emergency medicine palliative care are using to talk about and think about this evolution in these different models. So we'll just spend a quick moment talking about each model. So the first one, on sort of the least evolved end of the spectrum, is frankly where we sort of are here at MGH. So this is the traditional consultation model. And so in this model, you have ED clinicians who can request a consult from palliative care sort of at random, right? There's no real systematic way to screen patients or to think about who gets consults and who doesn't. The emergency team are really not all that clear what happens once they do get a consult, if they do, which doesn't happen all that frequently. And so that's sort of the world that I would say we are just at the end of, and we're moving towards this basic integration model. We definitely have more of a working relationship between ED and palliative care in that we have a scholars program, and so two of us have served as sort of starting to work a little more collaboratively. But where we haven't gotten yet is really thinking about broad-based program goals, a mutual understanding of what are the processes and functions that each department, each group can play to help support the care that these patients need, and then starting to really get into that training for frontline clinicians. As we continue to evolve these models, you start to end up with tools and protocols that can really help guide care. And these institutions, very, very few of them out there that are doing this, but really talk about the importance of the systems to support the care. And so you have systematic ways to identify patients. You have systematic ways to get consults and to understand sort of, is there, and we'll talk a little bit more about this in a moment, but a dedicated resource that really thinks about the work that they do in the emergency department is a little bit different than the work that gets done on the inpatient floors. That sort of speaks to that focused ED assessment, and then of course more training along the way. And then this is sort of the goal. So the holy grail, I think there's like maybe one or two places in the country that are really doing this, where you have dual certified emergency medicine, palliative care staff, where you're highly leveraging nurse practitioners, physician's assistants, thinking about how can this really be an integrated team approach to palliative care in the emergency department, where you've got clear protocols both within the ED and then sometimes protocols within something like our ED observation unit for these common presenting symptoms. So things like pain, dyspnea, bereavement, broad access to understanding what the community resources are and issues around placement. Often they have folks that deal directly with the hospices that can think about this sort of very bumpy transition we have right now, which is from ED to hospice, is a tough one to make. But so you put in systems that can support that. And then this idea of the sort of near complete primary palliative care, that the ED has embedded resources that really think about owning that function. So any questions about that sort of model of palliative care, of what that looks like? Okay. So how are institutions getting there? So the irony is that most of them are getting there with ways that are not particularly effective or efficient, which is why we haven't seen it really widespread yet, really attacking it with education. which, although incredibly important, we all know that without systems to support care is really a challenge. And so here you see clips from 3 programs which EM Talk, I'm sure many of you are familiar with. They've now rolled out an emergency medicine curriculum. And then up top from the emergency ACEP, the American College of Emergency Physicians, so our biggest sort of specialty organization, has really called on this, on increased palliative care and emergency medicine as a really important focus for the next decade. Choosing wisely those guidelines, which you may have heard about, they really called out palliative care engagement within emergency medicine. So one way that we're starting to think about getting there is through advocacy, through these big organizations calling on this to happen, and through education. But we certainly need to do more from a system perspective. At MGH, when we first thought about how we were going to get there, we spent a lot of time meeting and a lot of time thinking about how can we improve the quality of palliative care in the emergency department. And that was the size of the question. And we spent a lot of time thinking about the different populations within the emergency department, and ultimately decided that we wanted to identify a small population, as with all good quality improvement, right? Start small, and try to really make an impact with that group. And so we talked a lot about what the different groups were that we could focus on, and what we ultimately landed with here was Anna. And when we sort of thought about this, one of the big questions we had was, where was the biggest pain point in the emergency department for the staff? And so we talked a lot about all these different patients, all of whom had unmet palliative care needs, all of whom could really benefit. It was a question that ultimately got us the patient population we decided on, was really about this moral distress within our staff, which was really palpable and very real. And so, who is Anna? So Anna is, in this case, a 96-year-old patient who has advanced dementia, COPD, on 4 liters home oxygen, and CHF, who recently made the transition from living at home with her daughter to full-time hospice care. And so she comes into the emergency department in the middle of the night, as patients like this often do, right, with shortness of breath and fever. And she has an advanced directive with her that says DNR, but really doesn't say anything else beyond that. And so very little other direction. And Anna, unfortunately, isn't able to provide us much history at all on account of her advanced dementia. And so naturally, what happens in the ED? We work her up for a PE, right? No, like really, that is what we ended up doing. It's remarkable. So we got labs, including tropes and BMP and chest x-ray and flu swab. Seemed like a reasonable initial assessment, right? But because she was a little bit tachycardic, a little bit hypoxic, she had this low-grade temp, and she had no flu and no pneumonia on the chest x-ray, she got a PECT. And so she got a PECT, which was negative. And then at one point, her SATs began to drop even more, and she became even more confused than her baseline. So she ended up on positive pressure. She was on positive pressure, but unfortunately, her respiratory status began to deteriorate. And this is a case from our emergency department. So her respiratory status began to deteriorate and was having more difficulty breathing. And there was this like huge scramble to understand, like, is Anna DNI? Like, should we be intubating Anna? And so the intern calls Anna's daughter and says verbatim, I understand that your mother wouldn't want chest compressions, but if we thought there was a reversible cause of her difficulty breathing, would she want a breathing tube to temporarily support her? Right? So right. So what does she say? Of course, right? It's mom, right? I know. So what happens? Anna gets hypotensive peri-intubation. Doesn't recover after the vent, after she's placed on the vent. So she requires pressors, central line is placed, she started on Levofed, and 5 hours after Anna hits the door of our emergency department, she ends up in the NICU, okay? So I know I'm preaching to the choir here, right? And this isn't meant to be an M&M on Anna's emergency department care, right? But try to think with me for a moment the position that the ED staff is in, right? It's challenging. And they don't want to do any of this, like barring maybe the intubating intern who like hasn't had a lot of exposure to medical futility, right? But this case, which happens all the time, causes a tremendous amount of moral distress in the emergency department, and the staff leave devastated. And so the question is, how can we create a world in which this is not the standard of care in our emergency departments? So how did we do that? Or how do we think about moving in this direction? And so we thought initially that this patient population who arrives from hospice to our emergency department seemed like a really great place to start, right? Low-hanging fruit. Cause a tremendous amount of moral distress for our staff, and seems like there's a lot we could do for them. As we've actually recently been talking about rolling out our intervention, we've broadened our scope a little bit to also the CHF and advanced cancer population. And so just a word, as I spend half of my time in the Center for Quality and Safety, and so quality improvement is like really my thing. And so just a quick word on sort of how we would think about doing this. And so we started off with a needs assessment. And so we spent 6 months collecting data on who these patients were, right? I can tell you that's like the most painful part of all quality improvement projects. You really just want to like roll out an intervention, but really tried to take our time to understand who these patients were. When are they coming in? Why are they coming in? What happens once they're in hospital? Understanding that all of these things are really going to be important for us to understand if we want to design an intervention that's really going to be high impact. We knew that we needed champions, and so we had both physician and nursing champions to really think about who are emergency physicians or emergency clinicians who could think about really leading this work. We wanted to know who else was doing this, and so there was a hospital down in New Jersey that's actually has palliative care embedded full-time in the emergency department and is really leading this work. They're doing a little bit of this out at Scripps Mercy as well, and so went down and sent groups out to go and actually visit these high-performing sites to understand how do they do it. And then in the meantime, understanding that we also need to be aligning the work in the emergency department with all the work that's happening at the rest of the hospital. We're continuing to do the same type of education that's happening everywhere. And so making sure that folks in the emergency department have just these like really basic skills to understand like what is the advanced care planning module? How do you access it? How could we think about documenting some of these conversations as we encourage folks to start having them? And so those are sort of the groundwork that we've laid, but ultimately what we understand is that we're gonna need systems to really make this happen. And so the systems that we envision coming to fruition soon are gonna be things like observation protocols. So think about leveraging our observation unit as opposed to the world in which 90% of our hospice patients get admitted to hospital, right, that come through our emergency department. How can we think about alternatives to admission? And those alternatives to admission may be something like our observation unit, may be something like home hospital, or what we really think the biggest impact piece is going to be is creating this palliative care emergency medicine role that's really embedded in the ED to help connect folks with best care. So ultimately, I think that hopefully the answer to exactly what will be the best way to provide high quality patient-centered care in the emergency department for patients with life-limiting illness is not although it's not totally apparent yet, hopefully in speaking today, folks have walked away with a sense that it is a worthwhile nut to crack, and it's important to think about that there's enough of these patients and enough of a need that it's a worthwhile goal. And that ultimately, when we think about the impact that it could have, that if most of these patients impact or index conversation is happening in the emergency department, if we were able to have that conversation be done in the most skillful way with the most skillful providers, that we could really change the trajectory of their hospitalization or even their discharge home. So here, I think some of the big takeaways that we hope to talk about is that there's a need, there's a huge opportunity for impact, although very little formal research exists around the actual outcomes within having done this. There's enough other research out there that I think suggests that the impact would be pretty tremendous, both on patient and hospital-centered metrics. There are lots of different models out there, and then we're really focusing our attention right now on hospice, and then secondarily on the sort of CHF and advanced cancer populations. So I wanted to sort of open it up, spend time on some discussion and some questions.
Hello, that was excellent. Thank you. We are case managers here at Mass Gen. We were wondering if you've engaged the case managers in the ED-OBS and the ED in helping with these transitions of care for a percentage of this population?
Yeah, it's a great question. We have not to date, but we should for sure. And we've definitely talked a lot about it and about thinking about how that is just an absolutely critical piece, especially as we think about some of the biggest interventions here around connecting people with resources and understanding what they have access to within both the community and within their other supports. And so definitely something that we have talked about, although we haven't done.
They could certainly transition them directly to hospice or SNF with hospice or home right from the emergency or ED-OBS unit.
Great.
If that's what the patient wishes. You know?
Yeah, absolutely. And I think that's a really important point, and understanding that we certainly have lots of case management in the emergency department, and we have them both in the ED and in ED-OBS, and we actually round in the morning with case management in ED-OBS, but understanding that case management, just like all the other specialties, is broad, and that if the folks that are working within the ED-OBS right now are not really tapped into that world of palliative care specific resources and the hospice resources, that's not what we're often thinking about and doing. And so how do we make sure that there's even the cross-disciplinary working within case management? Case management in general, yeah. And yet when we look at within our specific environment, it tends not to be as much the focus.
Other questions, comments? Thank you, Emily. This is really quite fascinating work. So I'm Julia Gallagher. I'm the medical director of the home-based palliative care program. So we're trying to keep your front door as unbusy as possible, and we'd love to help you with your back door. But there's so many things that I think your talk brings up, right? Is, if the ED doc is having more continuity of care with a patient, that's probably a patient that needs palliative care, right? But also, issues around how difficult it is to communicate and have good quality communication across care sites, right? Yes. Like for hospice patients coming in, kind of what does the ED doc know to do in terms of what hospice was the patient on? How do you communicate with the hospice as to why was this patient sent in now and what are the goals? Yep. And I'm also interested in your work in terms of how many patients, when you went back to look at this, how many patients from hospice presented here, and are those comparable numbers across our other RSOs? Like, is the Brigham seeing the same volume, Newton Wellesley, North Shore? Yeah. Because there is a hospice collaborative that's just been developed.
Yep.
And maybe some of these communication issues could be actually explored in that setting as well.
Definitely. So I think, so there's a lot of really interesting things to unpack there. I think this first piece, it's interesting. So you say like the ED doc being able to know all these things about the hospice they came from and where they could go. And I think the one thing I would push back a little is say, is it the ED doc that should know those things? And in the few places that are doing this well, they actually, and it's similar to actually the work, we often draw the parallel to the work that we're doing with addictions right now. We have a full-time, he's a nurse practitioner by training. He's really an addictions counselor within the ED who, Joe, is amazing. He's like deified down there. But what he has done is that really anytime these patients hit our door who have substance use disorder, Joe like self-consults and is by the bedside, working with them about detox facilities, where could they go, where have they been, what do they qualify for, what are sort of meets their needs best, and has really, we've moved away from a system where we're trying to get all the ED docs familiar with how to have that skill set, and now it's somebody else within the ED. Interesting thing about that is everybody in the ED now is significantly more skilled at all of those things because Joe is there. So because Joe circles back and says, hey, I just saw your patient over there, here's where he's been, here's where I think he could go, here are some of the things that I'm thinking about around his addiction, and we all get this sort of secondary education that really improves our game for the hours that he's not there. More of those conversations are happening primarily that didn't used to happen. But I think that that model, as opposed to that we need to have all of the ED docs skilled in understanding the whole landscape, that what's interesting is the only places that seem to be really successfully doing this are places where they've chosen a slightly different model, which is having somebody else that's really skilled in the ED providing a lot of that. And so it's definitely something that we need to think about. To the piece around the volume, so we're just finishing sort of analyzing all the data from the hospice needs assessment. It's way bigger than we thought. Right now it's looking like almost just under about a patient a day. Yeah, which seems tremendous. You know, the data's a little bit confounded, which is why I say we're just finishing the analysis, because we're actually now going to do a secondary data collection. Because it turns out that not all emergency physicians know what hospice is. And so there was some confusion when we asked if your patient was on hospice, that if they had palliative care involved, that some of the care providers would say yes. So we're working on getting that sorted out. To your question around, is it the same in other RSOs? We have no idea because nobody knows. So the other RSOs don't know this. There's no coded field in Epic that allows us. So we literally did prospective manual data collection to try to figure out how many patients come from hospice, because there was no way to pull this data from the chart around in the Epic ASAP module, how many people come into the ED from hospice, which is like shocking. And for that same reason, there's no literature out there. There's like one very poorly done study that tried to look at what was the prevalence of this patient population, and they were in a different part of the country in a community-based setting that was hard for us to extrapolate from.
Other questions?
Hi, thank you very much. I'm wondering what role, if any, the MOLST form is playing. Where was Anna's MOLST form?
Yeah. When it's there, I think it does play a role. It's not always there, which is the challenge. The number of times that patients come in at 4 in the morning from nursing homes with like, you know, one side of it photocopied and the other not, right? It's like so painful. And so, but I think when it is there, you know, the ED almost to a fault, I think sees it as like, we've got this form, we need to do, you know, exactly what it says there. as opposed to actually like reinitiating some of these conversations if things seem to be evolving, especially when it's dated like, 2009. But yes, I think that being the protocolized specialty that we are, if there is a form that is present, which is always the challenge, but if the form is there and it tells us exactly what we should and should not do, like folks will abide by that, for sure.
Hi, I'm actually in a group with Mara Kennedy, and she's trying to identify patients with dementia and delirium.
Yeah.
And that's the biggest struggle that we're trying to have is who gets screened. And I'm thinking, wouldn't it be great if somehow you could parlay on to her to somehow trigger this consult with ones that are identified, because it's a Governor Baker initiative. I mean, it's gonna have to happen. And that seems like a huge population that could benefit from palliative care.
Definitely. And we're working really closely with Maura. I think it's really interesting to think about what did these circles look like. Maura Kennedy is faculty in emergency medicine who's really focused on geriatrics and thinking about caring for the geriatric patient population. So there's a huge overlap when we think about unmet palliative care needs and the geriatric population. And so definitely thinking across, trying to combine as much of this work as we can. And when we think about a resource in the ED, definitely the idea would be that it would be somebody that would hopefully serve all of these populations.
Thank you for your work. This is awesome. And, if we could even be more upstream and have this education at these extended care facilities, of course, that would even be better. I remember looking into this work some years ago when we were trying to do it in Detroit. And it's so counterintuitive to what the emergency department does. I think it's fabulous that you're looking at the hospice population because people come to the emergency room to live, and you're trained to help people live, where these people are coming from hospice to die.
Right.
And that is, in defense of that intern, I mean, that's his mode.
Totally.
This person wants to live. I'm going to do everything I can. Where, as that decision's already been made, that death is going to happen, and it's so hard to make that transition. I think it's fabulous work, and I hope that we can somehow help make that stop happening.
Yeah, and I think that's exactly, therein lies the challenge, is like, why are they here, right? And so often you'll hear from people, well, like when we talk about could we get them back to hospice, it's like, oh no, this was a failure of hospice. They failed hospice, so now they need an inpatient admission, right? Yeah. But this, I think that the feeling is they were there, and that wasn't working, and so they ended up here, and so now they need to go somewhere else because they, and that's what we need to unpack, is sort of how do we get folks' minds changed around why they came in, which often could just be, for the home hospice population, this like caregiver distress, and like something wasn't working, and it doesn't mean that it's something that is, it could never be fixed, or we couldn't in some way help support if we understood a little bit more about what that root cause was to get them back to that environment. But there's no question that there is a strong sense in the emergency department that like they cannot come from whence they came, like they cannot go from whence they came. That like if they failed home a trial of outpatient management, even for other diseases, right? Like we see someone for pneumonia, they go home, and then they come back, and the idea is like, well, they failed outpatient management. And so now, it's imperfect.
I'm going to open it up to any questions at our remote sites. Or any final questions here? All right, we'll end there. Thank you so much, Dr. Aaronson, for opening our lab.